Hello, everyone, and welcome. We are so excited to have you guys join us this evening, afternoon. I don't think it's morning anywhere that I know of right now. We are so glad you're here for this important conversation about pregnancy and postpartum health after weight loss surgery. So whether you're considering pregnancy, you're currently expecting, or navigating postpartum recovery, this discussion is all about making sure you have the information you need to feel supported in your journey. For those who don't know me, my name is Marie Boone Clark, and I am founder of Birthing the Magic Collaborative, along with Dr. Valencia Walker. Our work centers on making sure that Black birthing people and those who care for them have access to culturally safe, science-based information. I'm excited to be here for this conversation with these amazing physicians. First, let me introduce you to Dr. Yamicia Connor. She is a powerhouse OBGYN, physician scientist with a passion for innovation. She has a deep commitment to improving women's health, and she has expertise spanning multiple disciplines, not only medicine, but science, engineering, entrepreneurship, and public health. Dr. Y brings a unique solutions-driven approach to tackling health inequities, and we are so honored that she's joined us. In addition to her clinical work, Dr. Connor founded Dia Sara. I've been practicing that as a Southern girl, and I know she's going to correct me with her beautiful accent, as a direct response to the medical racism and substandard care that too many women face. And I'm going to allow her to share a bit more about this amazing concierge style service. She's also co-founder of Race to Better Health, which is a nonprofit that takes an interdisciplinary approach to patient-centered engineering health equity. Also joining us is the brilliant surgeon, Dr. Shani Belgrave, who is a highly skilled, minimally invasive bariatric surgeon with Peachtree Surgical and Bariatrics. She has dedicated her career to advancing surgical care and mentoring the next generation of medical professionals. Dr. Belgrave was recently recognized as the 2025 Young Physician of the Year, and she's been named top doctor by the Atlanta Magazine. She is a strong advocate for weight loss surgery and patient wellness, frequently featured in media for her expertise. And beyond the operating room, she is the host of the Coalition Talk Show, where she breaks down health and wellness topics on YouTube, Spotify, and Apple Podcasts. We're thrilled to have both Dr. Shani and Dr. Y here for this conversation. Before we deep dive in, I would love for you guys to fill in any gaps that I may have had with your bio, just so that everyone is grounded in all the work that you're doing. Dr. Shani, do you want to go first?
Sure. Thank you so much for that lovely introduction. I appreciate it. As you stated, I'm Dr. Shani Belgrave, Atlanta bariatric surgeon. So most of my work focuses on the treatment of obesity, which is the medical term for excess body fat. And we're going to talk more about that shortly. But that's what I spend a lot of my time doing. As you stated, I am very involved with medical student education, as well as mentoring students and young physicians. And I'm very excited about my health and wellness show, the Coalition Talk Show, where I bring expert guests on to cover a variety of health and wellness topics. Thanks so much for inviting me to be here.
Thank you. And Dr. Y.
Everyone, my name is Dr. Connor. I apologize. I have a terrible cold, so my voice might cut out at some point. But I am an OBGYN physician scientist. I am a mother of three and a founder of Diosada. Diosada is a women's health company that is focused on improving obstetrical and gynecological outcomes for Black women and other women of color. And we do that by really focusing in on preventing obstetrical emergencies. And so we support women in a lot of different capacities, direct advocacy during the point of care, but also providing them support, education, wellness, a variety of different services.
Wonderful. Thank you so much for that. So I think to ground everyone, and I learned this in just starting to work with Dr. Shani, is that there are actually different, when we talk about weight loss surgery, there are actually different procedures. And so Dr. Shani is going to ground us in that first. And Dr. Shani, I have your slide pulled out, and you can tell me when you want me to advance. but we'll start with gastric bypass.
Perfect. So, as you stated, there are a few bariatric surgeries and procedures that are being done. I'm going to go ahead and talk about the more common ones as well as some newer techniques. So, the Roux-en-Y gastric bypass is one of the older procedures. It's been around for a long time, and there's a lot of good data on it. And with the gastric bypass, these procedures are done with the small incisions in a camera, so it's laparoscopic. And I always explain to patients that there's two parts to a gastric bypass. The first part is making a pouch out of your stomach so that you're only holding food in a small part of your stomach, and the larger part of the stomach is bypassed. Food bypasses the larger part of the stomach. That's why it's the gastric bypass. So the first part of the operation is making a pouch out of that top part of your stomach, as you see in the diagram. And then we go down a ways in your small intestine, and we divide that intestine in two and reroute them so the intestines are then in a Y. So the way that this operation works for weight loss is a few different ways. Number one, you're going to get a sense of restriction because food has a smaller reservoir to be held in. Number two, when we do this rerouting, you get stimulation of GLP-1. That's a hormone that's actually made by the intestine. It's what's being stimulated by the GLP-1 agonist, Wegovy, Zepbound, Mounjaro. All those medications are stimulating GLP-1, and you get that effect when you do that rerouting. And then the third way that the gastric bypass works is it's what we call malabsorptive. So the intestine is how we absorb nutrients, and when we do this rerouting, you absorb less nutrients. So that is the laparoscopic Roux-en-Y gastric bypass. And then I'll go to the next one. So the sleeve gastrectomy is also a very popular weight loss surgery. In the United States, the sleeve and the gastric bypass are the two most commonly performed procedures for weight loss. So with the sleeve, the way this is done is we're surgically removing about 80% of your stomach. So you can see the before and then the after. So you go from a football stomach to a banana stomach. And the stomach makes a hormone called ghrelin, which is the appetite hormone. So when we remove a large part of the stomach, one of the ways this operation works is you have appetite suppression. There's also some restriction because you have a smaller reservoir to hold the food. So that's the sleeve gastrectomy. Next slide. So the lap band is not as popular as it once was, but I included this because there are still patients that have a lap band, so I thought it'd be useful to know what it is. And so it's a ring that is laparoscopically placed around the top part of the stomach, and then there's tubing that's connected to a port, which is felt right underneath the skin on the abdominal wall. And so in the clinic setting, what can happen is a syringe with a needle attached can be used to put fluid into that port. The fluid then goes through that tubing and into the band to make the band tighter as needed. And fluid can also be pulled from the band to make it looser as needed. And the way that this one works is, as you can see, it's kind of having a pinching effect on the top part of the stomach to help people eat less. So that's the lap band. Next slide. So this is the endoscopic sleeve gastroplasty. This is been around since 2013, but it's still fairly new. And so this is different than the others in the sense that this is not a surgery. This is a procedure. There are no incisions. And if you look where it says the stomach before ESG, that black tube is actually a camera called the endoscope. So the camera is placed through the mouth and advanced into the esophagus and then into the stomach. And on the end of that camera, it's not in this diagram, but on the end of that camera, we attach a suturing device. And we're actually able to put stitches on the inside of the stomach through the mouth to reduce the volume of the stomach by about 80%. And so that's what they're showing you in Section B, stomach after ESG. You can see how the stomach has been made smaller in size. And so that is the ESG.
Great. Thank you, Dr. Shani. And so now that we've talked about the various surgeries, it probably helps some of us who are lay people understand why there may be some implications from a pregnancy standpoint, right? And so I'm going to ask Dr. Yamicia to share a little bit about how these surgeries impact fertility.
So bariatric surgery has impacts on both fertility, but also the pregnancy experience. Specifically on fertility, I have a few slides here. May I share my screen?
Oh, yes, please.
Can people see that?
Mhm.
Or is it too small?
Okay.
Is it too small?
I'm old, and so yes, for me and my eyes.
Okay, I'll change it. Is that better?
Yeah.
Can you see the entire, is it showing the entire screen?
If you guys could put in the chat whether you can see it or not. Now that is, I can see that. So
Okay, perfect.
perfect.
Great. Um, so bariatric surgery can have a variety of different effects on the reproductive, also the pregnancy experience. So things that we want to think about in patients with bariatric surgery are really nutritional and metabolic deficiencies. The nutritional deficiencies that we, highlight for patients are an increased likelihood of being anemic, and so iron supplementation is recommended. We also recommend daily calcium, and then increase in the amount of protein intake daily. So what happens, I don't know if Dr. Belgrave, you're going to talk about it, but when you have, after bariatric surgery, you can have basically absorptive issues, meaning that the bowel, the small intestine doesn't absorb as effectively. And that leads to the nutritional deficiencies. I think we're going to talk about this a little bit later.
So bearing in mind that there are these nutritional deficiencies, either doctor, whether I'm pregnant or not, are there specific vitamins that I should take or?
Yes, so everyone should be taking a multivitamin, a prenatal vitamin. That's for all pregnant women. You may need extra folate supplementation depending on your history. So, for example, if you have a history of neural tube defect, you'll need more folate. But these are the particular supplements that we add in addition to the regular prenatal vitamin or increased folate. We also add iron and calcium.
Okay. So protein, calcium, and iron. And does this extend then when, well, I'm jumping ahead to when the baby is born.
Yeah, so yes, we have it's a little bit different postpartum, but I didn't know if you wanted to talk about that in a little bit.
Yes, I'll do it in sequential order. I won't get ahead of myself. So given that there are some common nutritional deficiencies post-surgery, are there any impact or is there an impact to conception?
So yes, if you conceive after the recommended amount of time, so we want patients to wait at least a year, then there's actually improved outcomes for conceiving. So a patient, for example, who have decreased fertility due to, let's say, metabolic syndrome like PCOS, and they're also obese, they have bariatric surgery, often they will have improvement in their fertility outcomes. However, if you have a pregnancy too close to the surgical date, it can actually lead to several complications. So the baby can be small for gestational age. So this would be mostly due to some of the nutritional deficiencies you get. Also, you can have just other surgical complications because the surgical site, I mean, Dr. Shani probably knows better, but the surgical site just isn't completely healed. And the pregnancy adds a lot of intra-abdominal pressure, and that can impact the healing.
So, in reference to what you were talking about with the effects of bariatric surgery on conception and fertility, I just wanted to add that bariatric surgery has been shown to decrease the need for women having a C-section, decrease macrosomia, or having a larger infant than is medically ideal. It also decreases the risk of gestational diabetes, preeclampsia, and hypertensive conditions of pregnancy. So weight loss surgery is not only beneficial for increasing fertility. I've seen a lot of patients with PCOS be able to conceive after weight loss surgery, but it also, as Dr. Connor was saying, does also help improve pregnancy outcomes as it relates to the infant.
Right.
Right.
So it can reduce the incidence of diabetes. Did you say resolution of hypertension?
Well, weight loss surgery many times can help people have reversal of diabetes or improvement or resolution of high blood pressure. But I was referring to women that have bariatric surgery and lose weight prior to pregnancy, or they're going to have lower risk of preeclampsia and other hypertensive conditions, pregnancy-related hypertensive conditions.
Wonderful.
And just so we're saying it clearly, the improvement in the pregnancy outcomes from the bariatric surgery is due to the weight loss. So the take-home point is obesity has detrimental effects on a pregnancy, that can lead to serious complications for both you and baby.
Say that again for those in the back.
So obesity can complicate pregnancies significantly. It increases your risk of, as Dr. Belgrave was saying, your risk of C-sections, also your risk of gestational diabetes. You're at higher risk of having pre-gestational diabetes. So that's type 2 diabetes is what we think about. You are at risk for having a macrosomic baby. So that is a baby that is too big. People with very poorly controlled diabetes, their fetuses could be at risk for congenital heart defects. And mothers with poorly controlled diabetes, that is a very that patient's risk in pregnancy is actually quite high, particularly in type 1 diabetics, but also type 2s that are very poorly controlled. They can have pretty devastating outcomes for both mom and baby. So, for example, stillbirth, or maternal death.
Thank you, Dr. Y. So with that said, let's go back. If we could, we said the ideal is that mama wait, or that the patient wait minimum of 12 months, 12 to 18 months before getting pregnant. Does weight loss surgery change how birth control or other contraceptives work?
So weight loss surgery, if I have it correctly, Dr. Belgrave, it affects absorption potentially of contraceptives. So if you think about a contraceptive that you take by mouth, like an oral contraceptive pill, like your traditional birth control pill, that would be affected. It should not have an effect on a contraceptive that work through another mechanism. So for example, an IUD or an arm implant, those should not be affected by weight loss surgery, as well as the other ways you can get estrogen containing contraception, like a ring or patch.
Yeah, I think that that's the safer approach, especially because after weight loss surgery, usually patients are on a gradual diet progression. So normally my patients are on clear liquids for a week, then they're on full liquids, then they're on pureed, then they're on softer foods. And so in addition to maybe not absorbing things as well, like in the case of a bypass, I'm always concerned with early on how much they're drinking and eating initially and how that might affect certain drugs. For something as critical as pregnancy prevention, I counsel them not to rely on oral contraception.
Good point. So now let's say we are pregnant. And what are considerations? How does someone who's had bariatric surgery, how does their pregnancy differ from someone who hasn't? We talked about the benefits if we are, challenges, if we have weight challenges, in terms of, they're less likely to have issues like diabetes, hypertension. Are there considerations to the good or to the, oh, we need to be cognizant of?
So in totality, the benefits outweigh the risk. And so a patient who has had successful weight loss surgery and has lost a substantial amount of weight, that person is going to have improved pregnancy outcomes on average. However, there are, of course, everything in medicine has risk and benefits. When you think about weight loss surgery, the biggest one we're thinking about is, again, like the nutritional deficiencies. And that should be overcome by, proper diet and also taking vitamin supplementation. But in patients who aren't doing that, they could potentially have deficiencies that lead to basically a small baby. And so, what would be different in this pregnancy is we would want to monitor them more in the third trimester. And so, that could look like a variety of different things. So, the baby can go, or sorry, mom could go in to get testing to look at the baby's heart rate and making sure that the heart rate looks appropriate, or you could get ultrasounds. There's a variety of different ways, but typically you want to keep track of those babies, towards the end of pregnancy.
So then we talked a little bit about nutrition, and how nutritional needs change after surgery. Is there a change then during pregnancy? Should I continue the supplements that we discussed before, or as you said, Dr. Y, taking the prenatal vitamin? I'm taking what else?
So everything that I was saying is with regards to pregnancy. So you have a risk of having significant iron deficiency, and so that can lead to anemia. Many pregnant women already have baseline anemia, and so this could make it substantially worse. Um, Also, calcium deficiency. And then you want to make sure that you're taking a prenatal vitamin. Most of the standard prenatal vitamins that you can buy at the store, they have more or less about the same components. The one difference would be the folate, the amount of folate or the amount of B1.
Great. So now I read somewhere, and tell me if, because I'm playing Dr. Google here. um, Either you or Dr. Shani, what is it about the glucose tolerance tests that they may not be as effective after certain procedures? Is that correct?
A lot of those patients actually have a hard time just tolerating it. That was my understanding. And so the glucose tolerance test, for everyone's awareness, that is a test we do at around 28 weeks or so of pregnancy. And the goal of that test is to determine if you are at risk for a diagnosis for gestational diabetes. So this is an acquired state of diabetes that happens in pregnancy. The way that that test is done, there's a couple different steps, but the first step, the standard way, is to do basically you drink like a very kind of concentrated, um, we call it glucola, but it's essentially sugar water, and that provides a standard amount of carbohydrates, and then we test your blood and look at your glucose level. If your glucose level is above a certain amount, then that will send you to like the next step. However, patients who've had bariatric surgery, that can actually make them, quite unwell, and several of them it's not uncommon that those patients can't tolerate the glucola. For example, it would cause them to vomit right after taking it. And so for those patients, a better option might be just doing actually finger stick monitoring. So just, go ahead and just bypass the glucola already and then do kind of the standard monitoring you would do for someone who is a gestational diabetic, collect some data, and then make a decision based on what that preliminary data tells you.
Yes, and to your point, what Dr. Connor is describing as some of the reaction to the glucola is something we call dumping. So, patients who've had weight loss surgery can experience a phenomenon called dumping, and it's just a name that kind of includes a constellation of symptoms. So, some of those symptoms can be nausea, vomiting, crampy abdominal pain, and it's because of the alterations in the anatomy that a high load of sugar or carbohydrate causes certain shifts in their hormones that then cause certain fluid shifts that can give all of those symptoms. So that's just so people are aware, that is a risk of weight loss surgery is experiencing dumping. So I always tell patients to stay away from things that are really high in sugar, not only because it will cause weight gain, but it can precipitate dumping as well. Another thing I tell my patients is to separate eating and drinking by 30 minutes, because sometimes eating and drinking at the same time can precipitate the dumping symptoms.
Um, and another consideration in pregnancy, I'm not sure if we're talking about this later, but pregnancy comes with a lot of just GI symptoms. So it's not uncommon for women to have increased GERD, increased acid reflux, or have baseline constipation that gets worse in pregnancy. And so for patients who are pregnant, who might have those issues starting with, and then they have bariatric surgery on top of that, it can make it quite uncomfortable. And it's really important. These small things that you think about, you're like, oh, the things that aren't life threatening are very important, though, for the quality of life of pregnancy. You get obsessed about constipation when you take care of pregnant women, because I've seen people have to be in the hospital for like, a week or so because their constipation was so bad, and they had so much discomfort and pain that it prevented them from being able to stay at home and tolerate like a regular diet, and so it can become quite serious.
Thank you, Dr. Y. That highlights the importance of having a care team that sees and hears you, whether that's your primary care OB or you have the relationship with Diosara. I can't say it.
Mhm.
Dr. Y's company. So let's talk a little bit about the weight gain. What is the recommendation, or what is the norm after surgery? What's considered healthy for me?
You mean in
Oh,
pregnancy?
I'm sorry. How does weight gain during pregnancy differ after surgery? What's considered healthy? Is it still the average 28 to 35 pounds, or is it less, or is it?
Well, it typically will depend on the patient's BMI. But if you're having weight loss surgery, then one could presume that the BMI is on the higher side. And so for many of those patients, the recommendation is actually quite small, like around 10 pounds or so, which is very difficult when you're pregnant. It's people can gain 10 pounds in the first trimester. And you have to remember the third trimester is when you gain the most weight. And so being very diligent about that can be challenging.
Now, is the BMI is it based on my BMI before surgery, or the BMI that I am at the time I'm getting pregnant, post surgery?
It should be the BMI at the time you're getting pregnant.
Okay.
So, but Dr. Belgrave, correct me if I'm wrong. A lot of these women aren't coming to BMIs of like 20. I mean, they're still sometimes 30.
So I'm so happy that we're circling back, because I wanted to make sure everyone knew some information. So obesity, which medically is a body mass index of 30 or greater. So everyone knows when we say BMI, And that's a number derived from your height and your weight. So if anybody goes to Google and puts in BMI calculator, it'll pop up. You can put your height and your weight in and you'll know your BMI. It's not a perfect tool, but it's pretty close. And so the textbook definition of a normal BMI is like 18.5 to 24.9 for reference. And so to your point, Dr. Connor, a lot of my patients, my goal is to get them to a BMI of under 30. That's really the whole goal because we know that 30 is where you start having increased risk for many medical problems, many cancers. So that's really the number I'm going to. And a lot of patients do get there. And I've had a few patients that they're concerned, well, I'm now pregnant and I don't want to regain all my weight. And so I'm glad we talked about that the weight gain is different based on BMI, but even at a BMI of 27, 28, 29, you still don't need to be gaining but so much weight anyway to have a healthy pregnancy.
Right. It's a lot less than people imagine. The concept of eating for two, it's that's inaccurate. You need about maybe 300 extra calories in pregnancy. If you're carrying multiples, you will need more. But that more or less adds up to maybe a sandwich. So you're not eating tons more food. You might be eating, a small extra meal or a few extra snacks throughout the day. But it's not this large increase in food. And I think that's one of the ways that it can be very challenging for pregnant women because you do get very hungry as well. And so making sure that you're balancing that, those cravings with healthy food so you're not having, out of proportion weight gain.
Good point. And what did you say, Dr. Shani? That sandwich comes in handy sometimes though, right?
Well, I wasn't going to go on my rant about low carb, high protein, the sandwich without the bread, so a lettuce wrap.
No, we should have that conversation. So we've had this wonderful pregnancy. It's time for labor and delivery. Are there any special considerations? Either of you?
I always defer to the OBGYN expert for that.
So you would deliver and manage that labor just like any other patient. Those patients are going to have, potentially an increased risk of C-section, probably below where they were before, but maybe increase compared to the, normal, quote unquote, normal population, because again, they tend to be a little bit higher on the BMI. But there's no real special, labor management. Labor's managed pretty much the same. And the same thing that would be indications for a C-section in a patient who hasn't had this surgery, it's the same for a patient who has had this surgery.
And what about anesthesia? So we've talked about C-section as a possibility. Are there specific considerations for anesthesia and or epidural?
I don't believe so. I've never heard of that. If that's the case, um, there are rare reports of people having, um, and these aren't things that we typically will see, but those patients can, have other GI issues. So if the patient presented or the patient arrived with, let's say, increased pain, that might be a patient that you want to look at a little bit closer, because there could be, um, something going on intra-abdominally. But otherwise, those patients more or less behave like other patients.
Great. So then what about postpartum? We've had the baby. We didn't have to have a C-section. We're going home. Is there anything that I need to consider that would differ from a mom who's not had bariatric surgery?
So moms who have had bariatric surgery can breastfeed. One thing, again, you have to be cognizant of is um, making sure to get enough nutrition because, again, in When you're breastfeeding, you will, the nutrition that you take in is what baby gets. Um, we recommend continuing to take the prenatal vitamin and then also the supplements that you were taking during pregnancy. But these women can have, issues with milk supply just based on, if they have a deficiency or they have caloric restrictions. But by and large, most women who want to breastfeed who have had bariatric surgery are able to do that successfully.
Mhm. Anything that you would add to that, Dr. Shani? Postpartum, does mom need to come, does that woman need to come back to see you for any reason? Or if she,
Not immediately postpartum, but I do like all of my patients to see me at least once a year. And so often when they come in a little after their 1 year visit and tell me they're having a baby, I'm like, well, make sure I'm gonna let your OB kind of take care of the immediate things. And but then once the baby's born, I do want to see you back so we can make sure we're keeping track of the weight. Because that's something that we want to make sure that we're following closely, that people are maintaining their weight and not having excessive weight regain. And that's just for all patients, not just for those who've had a baby, but I like to see everybody back at least once a year.
and this looks like and thank you,
Yeah.
Dr. Shani, and this looks like an interesting diagram, Dr. Why, will you take us through it?
Yes, so I just put up some information about postpartum weight loss after bariatric surgery. Again, these women have the same risk that we all do of gaining weight during surgery. I mean, excuse me, during pregnancy. But they have this. They could potentially have additional complications due to the deficiencies that we talk about, but also um, maintaining their hydration status. And then you have to make sure to monitor for very rapid weight loss. So you don't want to lose weight too quickly, if there's such a thing, because that could potentially be dangerous. And so because these women, may be restricted in how much they can eat, postpartum, they may have very rapid weight loss that could, for example, affect your milk supply. If have, a significant amount of weight loss and you become, for example, anemic or deficient in some, in a particular nutrient, or if you have a hard time maintaining appropriate hydration, those could all impact, breastfeeding moms is what we think about most often, but it could also lead to muscle wasting, because if you're not getting the nutrition, if you're not taking in that nutrition that the baby needs, your body will get it from somewhere else. And that usually will come out of your bones or your muscle.
Mm, that's an interesting concept. What about so I've had this surgery, I had that amazing body, and then I have the baby, and I've got some extra weight. Can I use things like Ozempic or any of the other GLP-1s while I'm in the postpartum period and breastfeeding?
Yeah, so I have some information about GLP-1 medications. The big thing you want to think about with GLP-1s is they're relatively new medications. So we don't have an enormous amount of data, and they haven't been tested on pregnant women. There are some concerns, particularly of GLP-1 medication while you're pregnant in the first trimester, that have been associated with increased risk of pregnancy loss, increased risk of congenital anomalies. So we want to make sure that patients are not, you know, intentionally getting pregnant while they're on a GLP-1 agonist. However, we know that the weight loss that you get from these medications will increase, could potentially increase a woman's fertility, especially if it's due to, for example, a metabolic syndrome like PCOS. And so there is a lot of anecdotal information that we're getting from just the population. So this is just population data, not people technically in a study, but someone who was on a GLP-1 inhibitor to get pregnant, and that information was collected. That will hopefully provide in the next couple years more information. But the standard recommendation is to not use a GLP-1 inhibitor while you're pregnant.
So don't use the GLP
Um,
while I'm pregnant, and that would
no,
also mean not to use it while I'm nursing. Well, correct?
and you would not want to use it while you're nursing. Yes, it's slightly different. The reasoning and the effect probably work through different pathways. So for nursing mothers, uh, it is we don't have enough information to know what effect the GLP one medication will have um, on the mother's breast milk. But what you can, you know, what you can reason through is that the reason we have to take GLP-1 agonists as a shot is because if you take it by mouth, the drug will not be active. And so, there are not recommended, but there are women who continue to use a GLP-1 inhibitor and are breastfeeding. And the rationale that they're making is that the medication should not be active in the baby because the baby's drinking the milk, it's going through the gut, that will activate the medication. However, although it makes sense, like the mechanism makes sense, we don't actually have the data to substantiate that. And so right now, the recommendation is not to use it in lactating moms. That might change in the future because, as you can imagine, lactating moms are also postpartum moms, and the breastfeeding recommendations are up to 2 years. The standard recommendation is up to 1 year, but they've kind of extended it to 2 years. And so that's a very long time that you are breastfeeding and not potentially losing weight. And so there are a couple of things to definitely weigh. But I would not recommend it to any of my patients, especially until we get more information.
Thank you, Dr. Connors. So then now, I don't know if there's audience. I've got a ton of questions, but you guys probably have some. So please drop them in the chat or use the Q&A function. And if I don't see any, one that I do see is around mental health considerations. What mental health considerations should be addressed during the postpartum period for someone who may have had weight loss surgery?
Well,
Oh, go ahead.
I was just going to say that irrespective of weight loss surgery, some women have baby blues or postpartum depression. And so that's something to consider and look at. And that separately, bariatric surgery patients many times are a part of support groups for, just lifestyle change and connection and things like that. And so I would say I don't know that there's any increased risk of having psychological issues after surgery, specifically to the fact that you've had weight loss surgery, was all I was going to add.
Mm-hmm.
Exactly. I mean, women in general are at very high risk of some sort of mental health issue postpartum. It's much more common than we think. Um, and anyone who has had what the data shows is that people who've had more complicated pregnancies tend to have a slightly increased risk of mental health conditions. So that could be someone who has multiples. That could be someone who's had severe preeclampsia. So there are a lot of things that are associated with it. So it's not just the actual condition, but it's just the psychological stress of having to manage an extra thing that puts you at higher risk.
Mm-hmm. So
Um,
I'm sorry, go ahead.
Well, I was
I,
just going to say, I just pull up the slide that just highlights some of the things that Dr. Belgrave mentioned. So body image challenges, there are women who find support groups really helpful, particularly with when they first have surgery, trying to find diets that work for them, that are both, affordable and they enjoy, and also don't cause any like GI issues. So there are things that could be helpful to have a community to discuss with after getting the surgery.
wonderful. And do you know of a specific like communities, Dr. Shani or Dr. Connor, for women who have had the weight loss surgery and then now you're a new mom? Or
Oh, I was going to say, I didn't know about the combination of surgery and new mom. I was going to say a lot of patients are on different Facebook groups. And then most of the hospitals where we do bariatric surgery, the hospital also has bariatric support groups.
Right. I always tell people to go to Facebook first because these sort of groups tend to live there.
Mhm.
And so you can find one in your local community, in your city, in your zip code, that where you can, potentially meet people online, but also meet them in person as well, to provide an additional layer of support.
Thank you. I've exhausted the extent of my brain, but I know the two of you have some additional things that you want to share with the group. And then again, for our audience, if you have questions, please drop them in. Or maybe we should do a recap. The first is I'd love for us to repeat the importance of the nutritional supplements and what nutritional supplements we want them to take.
When you have weight loss surgery, you have increased risk of nutritional deficiencies because it affects the absorption from the bowel. The things that we commonly think about: iron and calcium. And then you have the standard recommendations for all pregnant women, which are a prenatal vitamin, which the standard ones, if you go to the store, CVS, and buy them, they all more or less have the same thing. And then potentially, um, certain moms might need increased folate. So, for example, if they have multiples, or women who have had a previous pregnancy with a neural tube defect, those women should be taking higher levels of folate. That is independent of bariatric surgery, but those are the things that to think about. In a patient who is pregnant, who has bariatric surgery, but also could potentially have these other reasons to take different nutritional supplements.
Thank you, Dr. Y. Anything that you would add, Dr. Connor? I mean, I'm sorry, Dr. Shani.
I've thoroughly enjoyed this conversation. I love talking about health, wellness, weight loss surgery. And it was really neat to get the input from um, an OBGYN specialist to help let me know some things too for my patients. So this has been great.
And Dr. Connor, there's a great request that you had a slide on managing GI issues. Could we talk about that?
Yeah, let me pull them up. So, after bariatric surgery, you have increased risk of different GI symptoms, and so we spoke about dumping syndrome. Um, so, Dr. Belgrave, is that just with protein-rich meals, or also really fatty meals, and also like high in sugar meals? So,
Yeah,
what
so
type
it's
of
so I always counsel patients that it's really triggered by things that are really rich in carbohydrates and high in sugar. So, like you noted here, small protein rich meals
Mhm.
are the way to go. And then also separating eating and drinking, because sometimes eating and drinking at the same time can also precipitate the dumping.
Pregnant women also have increased risk of acid reflux or GERD, and that can be worse in a patient who's had bariatric surgery. So things you can do to try to help with that. Basically, staying upright at least 30 minutes after you eat. So instead of eating or drinking something and laying down, making sure that you stay upright. There are also medications that are safe to use in pregnancy to control GERD. And so we commonly use things like Pepcid. Most of the PPIs are actually safe in pregnancy. And then the big one for all pregnant women is constipation. The transit of the colon is slowed by the pregnancy hormones, and so at baseline, even a woman who's never had issues with constipation before in her life, in pregnancy, it might be different. And one thing that I recommend to my patients, if they have a tendency to um, get constipated, that we need to be very proactive. You don't want to wait until you are in a crisis and have to go to the emergency room because you haven't had a bowel movement in like 4 days. That is very, very uncomfortable. And so making sure to take lots of fluids, drink plenty of water, high fiber diet, and then you can take, a different, medications to try to help um, with bowel movement. So I typically recommend like Colace and then Miralax are, two very safe medications we use commonly in pregnancy.
Thank you, Dr. Why? So and I think we talked about this a little bit when we first met, preconception conversations. One of the comments from our guest is that this information should be included in preconception care. From a preconception perspective, what are best practices that you would share with someone who's considering pregnancy, and or for those practitioners who see patients and maybe I'm not as well versed?
So are you talking about all patients or specifically patients who've had bariatric surgery?
Oh, let's do both. Let's start with those who've had bariatric surgery first.
So again, that would depend on when their pregnancy occurred after surgery. If their pregnancy is, in a, close window to when the surgery occurred, they could potentially be at increased risk of pregnancy complications, like, for example, IUGR, meaning a fetal growth restriction, the baby's not getting enough nutrition. For those patients, I would recommend they could potentially benefit from a consultation with a high-risk obstetrician to make sure that there are not any additional recommendations that they have about either monitoring or their dietary intake. The real thing we want to know is about monitoring. Other than that, I don't think that um, there are things that you would have to do for obesity. And since obesity is found in this patient population, uh, that might, those are potential reasons that you might benefit from preconception counseling, but not from the surgery alone with a patient who's like achieved a more or less normal BMI.
And the other thing I was thinking is that bariatric surgery patients really are supposed to stay lifelong on supplementation. So if they're really compliant with that, it should help decrease some of the issues that we worry about at the time of conception, which is low folate and things like that. But that would be the other thing I would say is, for sure, if you've had surgery and you're trying to conceive, to really make sure you're taking your vitamins.
Exactly.
And Dr. Shani, what are some of the concerns if I'm not compliant? Not to scare people, but
Yeah, but as Dr. Connor was saying, neural tube defects, if your folate is low. And then not only that, but if you are not taking your vitamins and you haven't been getting annual lab work and you get pregnant and you don't have timely prenatal care, I don't know if you have anemia, because there's certain things that you are at risk for having, which could be anemia, and then certain other vitamin deficiencies that could potentially be problematic for the infant, like thiamine and other things.
thank you.
Mm.
We have 3 minutes. This has gone by so fast. I think we're going to need a part two. Can we talk a little bit about your closing thoughts? What would you want to leave our wrapped, is that the right word? Audience with?
Well,
I think,
I always have to encourage people who are obese to consider weight loss surgery. Obviously, I'm a strong proponent of it. I see people every day that have lost 100, 120 pounds, 150 pounds, and have a completely new lease on life, off insulin, resolution of reflux, urinary incontinence, because there's so many things that are talked about, but other things that people don't think about, like, yeah, urinary incontinence, arthritis, I mean, sleep apnea. There's just so many different conditions. And because obesity creates chronic inflammation in the body, when it gets better, a lot of other things get better that people didn't even think of, like multiple sclerosis. So my takeaway is always, if you are struggling with obesity, definitely consider bariatric surgery. The surgeries are safe. It's just as safe to have weight loss surgery as it is to have your gallbladder taken out, and we can get some great results.
I love that. And Dr. Belgrave is in Atlanta, for those who may not have caught that.
Yes, come see me in Atlanta.
Dr. Connor?
so what I want to highlight is obesity is dangerous in pregnancy. And so if trying to actively pursue a method of reducing your BMI, particularly if your BMI is over 40, will have substantial benefits for your health in pregnancy and then after pregnancy. Um, so things we get concerned about, like we were, talking about earlier, increased risk of diabetes, but also increased risk of heart disease, increased risk of preeclampsia, increased risk of C-sections, increased risk of macrosomic babies, meaning big babies, but that if you have a big baby, that also increases your risk of having a postpartum hemorrhage. So you can see how all of these risks just kind of compound on each other. And so, if a patient is struggling with weight, I think it is very reasonable if you're thinking about pregnancy, um, to see like a bariatric surgeon or a weight loss doctor to think about how to optimize your pregnancy outcomes. It's one of the few things that we actually can change. So many things in, pregnancy are just, your genes, like you don't know why some people get preeclampsia and other people don't. But this is one thing that could have a potentially significant impact and benefit for you and your baby.
Thank you. That's one quick question. And I know I'd said it was our last one, but we're going to ask this one very quickly. Let's talk about, we talked about folate a couple of times. And can we talk about, help our audience understand what is folate versus folic acid, right? And then are there some concerns around methylated folate for those who've had weight loss surgery?
This is actually very controversial in the prenatal vitamin world. So what the standard recommendation is, the argument behind the methylated folate, there's not enough substantive data for us to say one way or the other if there is benefit. Last time I looked at the data, there are some studies that show benefit, but as a medical community, we don't just rely on one study, right? We have to rely on a population of studies. And so there is a lot of pressure on women to find these really specialized prenatal vitamins. And honestly, I wouldn't recommend that. I didn't take that for any of my children, but I would recommend are the things we talked about. So making sure you're taking a prenatal vitamin before you get pregnant. And so if you are a reproductive age woman and you are having unprotected sex, you're at risk for pregnancy, probably should be taking a prenatal vitamin because you can, get at any point in time. And a lot of the early development, for example, for the, to prevent neural tube defects, that happens very early in pregnancy, before many people even know that they're pregnant. And so you want to, make sure that you're, taking your vitamins. Um, but in terms of what, I don't tell people to buy any special folate, or invest in the, designer brand, um, uh, you know, different formulations. Um, you should, the folic acid that's at the store is perfectly fine.
Dr. Shani, anything that you would add?
No, I was intrigued. I didn't realize that there was a controversy over that. So thanks for sharing that.
Yeah, there's a lot of things on like TikTok and Instagram. It's Instagram controversy. So, but it's sometimes it can, there are things that are very important in pregnancy. Um, it's important that you take a prenatal vitamin, but you don't need to obsess about the prenatal vitamin that you are taking. I would spend more of that time, thinking about how are you going to exercise in pregnancy, because that's very, very hard to do. And it makes a huge difference. Even, be able to go for a walk, up until the third trimester consistently. That's huge. Um, that's a feat in itself. And so if you're gonna take that brain power, and try to do something extra, I wouldn't invest it in the prenatal vitamins. Is all I'm saying.
Thank you, Dr. Shani. And that is a perfect segue to a couple of things. One, I have dropped both of these amazing doctors. I've dropped their contact information or their websites in the chat. We will also send this recording to you as someone who registered. We are offering a CE, so we'll send the recording as well as a QR code for you to access the information to get your 1 hour of CE. Speaking of weight or exercise during pregnancy, I have to do a quick pitch for our Safer Births Initiative, which is going to be the week before Black Maternal Health Week, so April 7th through the 12th. Both Dr. Connor and Dr. Belgrave and a slew of our wonderful friends are coming back to do almost like a marathon of maternal health education, one of which will be around physical, I don't want to say physical fitness, because if someone says that to me, I'm just like, I'm checking out. But your physical wellness during pregnancy. We're going to talk a little bit more around a plethora of topics, from those big things like preeclampsia to I can't think of everything. Community health initiatives. We will go live on Thursday at this website. We'll send an announcement out to our team, and it will include all the workshops that Dr. Y is doing, as well as Dr. Shani. Thank you all for joining us tonight. The last thing I want to share is Birthing the Magic is a nonprofit. All of the content that we create is available for free. And the way that we fund that is once a year. We don't beg you every month, but once a year we host a fundraising event. And this year is going to be so fun. We're having a virtual fashion show. And so an amazing woman of color, Black woman, who is a jeweler, Dorian Webb, is going to be sharing some of her jewelry. She's been featured in so many fashion magazines. She's got some gorgeous, gorgeous things. I'm feeling to see if I'm wearing any of her earrings today. And then also Cedric Brown, who is an Atlanta-based fashion designer. Cedric has a collection of gorgeous things, like this beautiful dress. And he's been featured on a number of television shows. If anyone's like me and you're a fan of Greenleaf, the mom on Greenleaf that wears those beautiful kimonos that she swirls around the house in, those are Cedric Brown pieces. So you'll have to join us on April 12th. And we'll have more information on this coming out in the next few days as well. So last but not least, I have to thank both Dr. Shani and Dr. Y for your time this afternoon. I know you are both incredibly busy. Thank you for sharing this information with us. Someone said, thinking about breastfeeding, chest feeding. We are going to talk a little bit more about weight loss surgery and your life after in terms of parenting and the postpartum period during Safer Births Week. So tune in for that. I know Dr. Shani is doing at least one other workshop for us, maybe two. And then Dr. Y, I don't know how many Girlfriend is doing. I keep sending her requests and she so far has not said yet no yet. So but there are going to be some amazing conversations. Thank you all so much. Have a great evening and we'll talk to you soon.
Thank you. Good night.
Thank you, everyone. Good
Good
night.
night.